Good afternoon, everyone. It's Sandy Dunn, the Knowledge Translation Specialist at Born, Ontario. Welcome to our Born Provincial Rounds today. We have an interesting session planned for you. I think you'll really enjoy it. Just before we start, I'd like to remind you that we will hold a question and answer period after the presentation is finished, and we'll encourage you to type in your questions into the chat box that's available on the left-hand side of your screen, and that this Born Provincial Round session is being recorded and will be posted on the Born website within the next few days, probably by next week. For any of your colleagues who aren't able to listen in today, it will be available for people to follow up on in the future. And so without further ado, I'd like to introduce our topic and our speaker today. Leanne McCullough is our speaker, and she's going to present an information about how we use born data, the St. Thomas Elgin Hospital Transformational Journey. Leanne is a registered nurse with 20 years of experience, and she's held a variety of roles from frontline staff member to educator to manager and director in her career, and she's currently the manager of Women's and Children's Program, the OR, PACU, and Risk Management for St. Thomas Elgin Hospital in London, Ontario. She has held a seat with the Maternal Newborn Advisory Committee and with the Provincial Council for Maternal Child Health, and she was also on the Pediatric Wait Time Lead with the Ministry of Health in the Central East LHIN. Most recently, Leanne has been appointed to the PCMCH Council, and maternal newborn services has been her passion for a long time. However, she's also had a significant leadership role in medicine, surgical services, and ambulatory care, so she comes with a great deal of experience. In addition to her current leadership role, she works in the capacity of a legal nurse consultant, and she has been retained by a law firm to provide expert opinion in obstetrical medical legal cases. Quality and risk have been in the forefront of her leadership roles, and using born data on a daily basis is truly a transformational experience and transforming how we deliver care within the program at St. Thomas. So without further ado, I'll hand over the mic to Leanne and the slides and let her go forward to tell their very inspirational story. Leanne?
Hi, good afternoon, and thank you for the opportunity to share our journey here at St. Thomas Elgin Hospital. So I'm going to just move into the presentation now, and am I able to move? Sorry. Yeah, okay, great. So as you can see, St. Thomas is certainly an older hospital. We're just currently in the process of our redevelopment and meeting with our architects as we look forward to our new build in 2017. So the objectives are to explore the importance of stakeholder engagement, to share how data drives change, awareness, and accountability, and to operationalize and evaluate major change and the sustainability of change. At the end of the day, it's really important to know your data and understand what it is telling you. So as you see here, we have a key performance indicator board. It's called our huddle board. Every day we run a huddle on our unit. It's about 15 minutes in length, sometimes a bit longer depending on some of the discussions that ensue. The individuals that attend this huddle are all the staff members that are on shift that particular day, in addition to some of our physicians, obstetricians, pediatricians, when they're able to attend. We also have our transformation office sometimes attend, and also our senior executives will often attend to get an understanding of what's occurring on our unit. So with this, what you're seeing on this board are some key metrics and triggers that we want to monitor every single day and discuss so that we have an opportunity to discuss where we're meeting targets and where we're not meeting target. On the top of the board, on the top left-hand side, that is our quality, risk, and safety report, of which I'll get into further detail in the presentation. In the center, the middle, at the top there, you'll see that is actually St. Thomas's strategic direction and initiatives that we have underway. And then on the top right is our board report. You'll see the way the board rows up is at the bottom. It's our daily components. Again, the center with our indicators, the daily, which then rolls up and aligns completely with our senior strategy and the organization's strategic direction. So on the bottom left-hand side, you'll see in the red square is our Born report. So that's a living, breathing document that we discuss on a daily basis. Next to it is the thought of the week, and that's an organizational thought of the week, something that we want to trigger for staff to think about. Right now it's Hugo, because we've just gone live with Hugo. The next document is called a countermeasure sheet. So I can talk a little bit more about that as we move forward in the presentation, but essentially a countermeasure sheet is when we're looking at our indicators on the board or any of our Born data indicators, and if we're not meeting a target, what do we need to do in order to meet it? And we document it down on the countermeasure sheet, identify who's responsible for it, and put a target date in terms of when it needs to be completed and done by. And we review those on a daily basis as well. The next document on the far right side is our patient satisfaction. So we understand that when we're making changes, we're not impacting the patient care experience in a negative perspective. So you'll see now here the firstborn dashboard I was presented with. I started here at St. Thomas Hospital in March, and as you see, this is the April 1st data that I'm sharing here. And so for me, it was it was March 1st, 2013 when I started here. So this is about a year's worth of data in this dashboard that I wasn't really part of, but it was really helpful when I first joined to have an opportunity to look at some of the areas of focus where we really needed to start to make some change. So when I looked at this data, upon discussion with frontline staff and the physicians, we chose two areas to start our work on because, as we all know, you can't take it all on at the same time and do a deep dive and make really sustainable change. Inductions have always been a bit of a bugaboo for me. Sorry for the terminology, but it's really been an area of focus for me in terms of moving practice because, you know, as we know, more interventions we do, we certainly have more impact on outcomes. We began some discussion within the program and our clinical care team, which is our quality interdisciplinary team that makes the decisions surrounding the program. And we also did some discussions on a daily basis with respect to, taking inductions as one of the first indications to work on. And on a daily basis, we discussed with staff, what are the reasons we're doing this induction? Why do we need to proceed with this? Does it meet the standards of care? And the appropriateness at the end of the day. Then when we kind of got a sense of what was occurring and continued to draw on this data and do some deeper dives into the Born data and pull information related to the inductions, and specifically the post-dates inductions that were less than 41 weeks of gestation, we started to develop some strategies with the key stakeholders to understand, to move the change forward. And so in respect to that, this is the approach that we took with every indicator that we've started to tackle. We have basically created this process in order to approach every indicator the same way. So when you look at, the huddle board that I was showing you on one of the first slides, the indicators that we started tracking was a couple of high-level ones related to occupancy. Currently, we're using total hospital occupancy because you want to have a high-level understanding of what's going on in the organization. We're now going to break it down into NICU, pediatrics, obstetrics, and labor and delivery, and L&D will be related to throughput and not occupancy, as you can't do it in L&D. But the second one is attendance, so that is related to sick calls, and this is an important aspect of care when you're providing quality patient care, having the right complement of staff with the skill set in order to provide that care. And we really built in the three-factor model from the College of Nurses related to that. And within the huddle board, we used the very similar bulleting of green, yellow, red, and so if we did have a sick call, we would mark it in red with a number 1, depending on the number that we had. The safety indicator was related to any safety-related incidences that were put through our electronic incident reporting system. We would discuss those incidences every day so that there was fulsome discussion and transparency in terms of what occurred and what can we do to mitigate the issues and prevent that issue from occurring again. And we would, if we had to come up with a solution, we would document that on the countermeasure sheet so that it was documented, and we would ensure that there was follow-up and then a report and response back, because that's really important for staff to know that something's being done. In relation to inductions, so we took the 41-week post dates and whether or not it was actually meeting the SOGC guidelines. And we would indicate the number of inductions and then the percent that actually met the targets. My target was 100%, that there was, if it was 41 weeks and it was documented as a post date and it was of low risk, then it had to meet the SOGC guideline 100% of the time. And if there wasn't, then there would be follow-up discussion with the key stakeholders and individuals and a complete review done. Unplanned cesarean sections. So for me, this was, I was trying to look for any correlation in relation to our inductions to see if there was patterns between our early inductions, if they were at 41 weeks or less, and if there was relation with the cesarean section. And I haven't finished that data analysis at this point in time. That is my next step in this process. The next indicator was hyperbilirubinemia, and the reason we chose that one, I should say, is because we know that the QBP related to hyperbilirubinemia was going to be coming through shortly, and I wanted to have an understanding of what our practice was like and our processes, and in particular, readmission rates. And we had just done a major policy change and process change related to hyperbilirubinemia, and so I really wanted to make sure we weren't impacting our outcomes and or readmission rates. The next one was NICU. So I'm not sure if other organizations have the ability to capture their NICU data this way, but the ability to accept NICU transfers or retro transfers from other organizations. How many telephone requests? We were getting regular requests from organizations, and I wanted to have a sense of how many we were actually accepting and or declining, and then I wanted to have an understanding in terms of the reason for the decline if we weren't able to accept. And we had identified on our huddle board, was it equipment, staffing, bed capacity, and so those were a couple of the indicators that we had chose specific to the NICU. The other metrics or areas that we decided to ensure that we were meeting our targets, not only through our indicator board, but also to be able to trigger us that we needed to do a chart review to see if we're meeting the standard. And so a chart audit trigger tool was developed that would help us to trigger, because we're not here 24/7. The staff and or physicians would complete this chart audit trigger, drop it into our mailbox, and then we would do an investigation on the chart to determine on whether or not we were meeting the standards and or targets on our metrics. So most recently, as you'll see later in the presentation, we have made some really significant strides in our data. And hence, as a result of that, we have made some indicator changes, and that being the cesarean section of low-risk women performed 37 to 39 weeks of gestation. And I'll speak further to this in the presentation. And the other indicator was pediatric length of stay, less than 24 hours. So I want to talk a little bit about stakeholder engagement. As we know, a structure of governance and any changes that you're making is really pinnacle and critical in terms of the sustainability of the outcome. So as I said, in terms of our infrastructure here, we do have a clinical care team, which is a interdisciplinary body who really has discussions and looks at our data. The Born report is discussed at there. We meet monthly, and so we discuss about how we're meeting targets and if we're not meeting targets, why, and what are some of the solutions that have come up on our countermeasure sheet that we could potentially move forward and develop further. The other group, as you know, is the frontline staff, as they're here 24/7 and really have a good understanding in terms of what is happening at the front line, what are the areas and challenges and opportunities that we can further explore. I regularly am in contact with our Born team, particularly my coordinator, Monica, who has been really helpful in doing some of those deep dives to further understand the data and also help me pull the data together to present it to the team, so there's a really good understanding of what we're seeing and why we're seeing it. We also have a very collaborative relationship with our public health team. So as we move forward in our BFI journey and looking at our formula supplementation rates, there are going to be key stakeholders in terms of supporting our community and sustainability of breastfeeding. Also in terms of educating the public, so when we do changes in terms of practice, really important to hear the voice of our community and the impacts that it may have with them and some feedback. We are looking at patient advisors. We haven't implemented that just yet into our program, but an area that we will be focusing on. So the public health has been very helpful in helping us move the voice forward into our program from the community. Obviously, the physician group, as they are a huge part of our practice within the Women's and Children's program, and having an understanding in terms of what their challenges are and opportunities to improve. And the senior leadership team, absolutely critical when you're making a substantial change, particularly in practice. And if it does entail the physician group, it's really key to bring them in to have an understanding of what changes you're making and why you're making them, and presenting the data as to why. And then my data analyst here within the organization. We're very fortunate in that we have data analysts dedicated to the programs, very small programs, so that I can regularly, again, do that deep dive of data and create visuals for our staff so that they can understand the data and what it's saying to us. So with respect to the stakeholder engagement, the other key point is really for us is when I was looking at the 30,000-foot view, I wanted to ensure that we were in alignment with the strategic direction of the organization. So in choosing our indicators, we were very thoughtful in terms of what our strategic map for the hospital was and the mission, vision, and values, and so that we could align our changes. And if I required the senior management support to really move a change forward, either be it financial or from a human resource perspective, that I would be able to garner their support because I could really show the alignment with the organization's direction. So that was really key. Implementing change. So as you know, with change, there's always sometimes pushback or, well, we've tried that and it's not going to work. And then you also have the individuals that say, sure, you know what, I'm happy to give that a try. Really important component really is when you're engaging the stakeholders, getting a metric that is burning for them was critical. Something that was at the forefront of the staff when they see a frustration, if you've got a metric that can help drive that change, is really beneficial. Is there a low-hanging fruit or a quick win? The sacred cows are a little bit more challenging and take more time, but if they start to see the change, it's obviously easier to move it forward, and they then will hopefully jump on board. The development of the strategies or the action plans to reach the targets with very clearly documented timelines. So as I said, similarly to our countermeasure sheet, which is on our huddle board, when we develop our strategies and action plans related to a metric or a measure, we tend to do Gantt charts, as this really works well in terms of identifying all of the different strategies, timelines that it will actually take to move it forward, and who are the key individuals that are responsible to drive that change. The understanding of what the roles and responsibilities of those individuals are key to really moving the change forward. Ensuring to get the voice of those who can impact the change as you develop the strategies. Again, that's stakeholder engagement, developing focus groups, because it needs to be a realistic change as well, because many times we can put things down on paper that aren't realistic in the real world. Completing the PDCA cycle. So anytime you want to move forward with an action or change, you always need to go through your plan, do, check, act. I think sometimes we will fall down in terms of, the checking piece. We plan it, we do it, we implement it. But do we go back and check it and make sure we evaluate it to see if it's the true solution that's going to impact or affect the change? And if it's not, it's that continual tweaking of what I like to say is the continuous improvement. So continuous quality improvement is not looking for those massive changes. It's really looking for continual, gradual, incremental changes. And do not take on, for us, we did not take on multiple significant changes at the same time. We did a bigger, deeper dive, developed strategies and processes that would be sustained over a period of time, and continuously did that reevaluation to make sure our metrics were continuing to stay in the positive side. And also a key point for us was to measure the before and after. So with our Born dashboard, that was really key because we could see our before and after in terms of how our metrics were changing. And likewise on our huddle board, you could start to see the transition from, significant reds to positive greens for many months, which for staff, that visual was really key, and they can really then celebrate that success because they are the ones driving the change forward on a daily basis. Again, in terms of the measurement, it's really key to have it visible, have your stakeholders engaged, be transparent, because the transparency creates accountability and awareness of what the data is showing you and where the changes could potentially be made and where we need to focus some attention. And always make sure you have a target and a realistic target. And that target can be a moving target. It can be set at a lower rate and then continue to push it forward. Again, it doesn't have to be, I've got to go from 0 to 100 in the next month. So be realistic. And then in the final piece for us is we are really focused on lean, as many organizations are, keeping that lean methodology as you develop your strategies for any of the changes that you're completing. And if you've got some lean experts within your organization, really key to pull them in as you develop those strategies. So upon our journey, as you can see, we did make some changes, and we were starting to slowly see some changes. Although gradual, we started to decrease our targets, and again, not necessarily as quickly as I would have liked to have seen, but I know sometimes you have to go slow to go fast. So as I said at the beginning, with our huddle board, our quality, risk, and safety report, this is our weekly leadership huddle that we do. It takes us about a half an hour, and what occurs at this point during this meeting is we discuss our metrics with respect to what we're seeing on our units and rolling it up to the senior leadership team so they have an overall understanding of some areas of focusing that we're looking at. as you can, it's difficult to see, and I apologize for the clarity, but on the bottom right, the second box in is deliveries. And kind of what we're measuring there right now is, slide to the next page, which is vaginal births, planned cesarean sections, unplanned cesarean sections, inductions, augmentations, newborn admissions to the special care nursery, and APGAR score of less than 10 minutes, because you always want to look at the outcomes of anything that you're looking at and making changes to in your indicators to make sure that you're not impacting negatively on your outcomes, which would be certainly your newborn. And the new indicator that we've just recently added was proportion of women with cesarean section performed, again, that low risk at between 37 and 39 weeks. So this is the next indicator that we are tackling with the born data and looking at practice changes. And we've certainly identified that there's quite a few systems issues related to booking the procedure. So we'll be doing some significant dives into that work. So sustainability, really when you're looking at sustainability, it's the knowledge and the knowledge transfer. We spent a lot of time with respect to the MOROB, as many organizations have, getting people on the same playing field, and likewise the SOGC guidelines, knowing the standards of practice and evidence-based practice, that continuous learning, that happens almost on a daily basis. Every time I speak to somebody about an induction, questioning, why are we inducing today? What's the reason or the indication? And continuously going back to, does it meet the SOGC guidelines? And so staff have become very, very familiar with the language within those SOGC guidelines, which is very beneficial so that they can have those discussions with the physician group as well. Vigilance and commitment is as critical, and I will get into that in the following slide. Empowerment of staff, again, empowering staff to have those respectful conversations with all of the key clinicians who are involved in the care of the patient that they're caring for, specifically related to the standards of care. I think this is a really important piece that staff feel that they can have those discussions and really help to advocate for the best outcome of each of our patients. Again, garnering the support of our senior leadership team in terms of either if we need to make changes for our resources and our systems to move evidence-based practice forward, it's key to have them on board and to help us challenge the status quo. Respect and credibility. Again, it's key to develop those relationships with all of our key stakeholders. Developing that credibility and understanding and having that knowledge is very beneficial so that you can have informed discussions in relating to the standards of care. Quality data. We spent a lot of time reviewing our born data and doing a lot of education around the data submissions, as our site is a real-time site, so when staff are providing care, they are submitting and inputting the born data. And it's critical that they have a full understanding in terms of the definitions of born when they're inputting the data. Otherwise, because data going in, bad data going in is bad data coming out. And you want to make sure that you're making informed decisions based on quality data. So we do a review on our born data weekly because our QRS report and the data that goes up to QRS is pulled weekly. So we are in born data, as I said, weekly, and we look at all of the data that is submitted through and make sure that it is making sense. And if not, we pull the charts and we'll do the review and then have discussions with staff in terms of what they've submitted and if they need to do any changes. And then the approach perspective. So, this is what I like to call the softer side of our world in terms of driving change. And it's the slow early wins, reviewing our indicators that are easier to change and less contentious, and really showing how if you've got the awareness of the data, you can really drive meaningful change to patient care outcomes particularly when there's very clear standards set out. Knowledge and knowledge transfer. So I spoke a little bit about this in the previous slide, but the standards of practice, again, going back to knowing the standards, the research, discussions with the experts, and there's many times where, you go out to the industry standard because there may not necessarily be a documented standard. Fortunately with BORN, there is clear evidence with respect to the standards, but on any indicator that we're tracking on our board, it's important to touch base with those individuals with that expertise. Because with this knowledge, then you can really guide your team and have informed discussions in terms of the care decisions that are going to be made and the changes that are required. Keep up to date with the SOGC and MOROB. As we know, SOGC, there has been some changes, and we speak that language on a daily basis. I tend to have my SOGC documents and MOROB documents ready on hand so that when you're having a difficult discussion, I can always go back and say, well, this is what SOG says, or MOROB states this. I found that has been very, very helpful because it's very objective and it's very clear because the data is there and evidence is there to support it. Formal and informal education. There is, as I said, daily informal education related to what it is we're doing, why we're doing it, and what are the standards of practice. And asking the right questions so that staff, now I'm at the point where staff come back and say, I had this discussion, here's what I presented, and here was the decision. Where do we go from here? Or, you know what, this was a really positive outcome. And in addition to the education piece, it's the mentorship of staff. So it's coaching staff on how to have those respectful yet challenging, or what I like to say, those crucial conversations with the key stakeholders involved in the care. And again, I go back to them with the standardization and the language, and that has been very helpful for the staff. And then continuing with the empowerment of the staff, encouraging and supporting them to advocate for quality patient care and standards of care. So vigilance and commitment. As I said, this is a daily review of the data. At the huddle board, daily investigations of our inductions and of elective procedures until practice change is embedded. It becomes almost innate, and that question is always, if something pops up and there's a red flag, the staff are automatically on the phone and or speaking with individuals that they need to in order to have that informed discussion. Our weekly review, so the BORN data, as I said, is pulled for the QRS meeting. We investigate cases, so what we use our trigger tool, and any purple that you can't see on the screen, but the trigger tool is actually purple. So we pull it out of our box, and we do investigations and pull our records and have those discussions with the key stakeholders to ensure follow-up is done if there is a concern related to the standards of care. Escalation to the chiefs of staff if there is a quality concern with respect to physician practice and or anesthesia. Having copies, again, as I said, of the best practices and readily available and on the unit and accessible for staff to refer to. Respectful conversations, not adversarial, gaining support from the champions to help influence the laggards was absolutely critical for us. The escalation process, so having a clear process for staff to understand if they have concerns related to care that's being provided and or decision that's being made, that what I like to say, the chain of command. So going to the clinical resource nurse, then escalating up to the manager, and then, it goes up to the chief, and, the staff are empowered to, if they need to, contact the chief of the department, and then the escalation process right up to the senior team if required. Because the staff need to be empowered that they can have their voice to advocate for the change and very clearly knowing what the standard is. And again, this really is about a commitment to quality patient outcomes. It requires daily monitoring, stakeholder engagement, and empowerment to sustain the change. Once you have sustained the change with little or no regression to the past practice, then you can move on to a new indicator as long as you have measures in place to continue to monitor the change, particularly the trigger tools and the dashboards, which are incredibly helpful. Setting the standard and communicating the expectations. So as we all know, as I spoke at length about, I apologize for my repetitiveness on this, but the SOG and Moral B, that is, our standards. And creating those policies and procedures and practices is really critical in order that everyone is very clear in terms of what our practice is. And communicating that out to the team, through many things like a read and sign binder, workshops, and whatnot. And then the follow-up performance management piece. The performance management is key in terms of if things are not moving forward or falling backwards, that follow-up is critical in order to sustain the change. And also have an understanding of perhaps why they're not able to meet the standard. Is there something in the way that we can help to remove that barrier in order to help them meet the standard? So really, in summary, for me, it's about know your data. Is it accurate? Reflect on what you have investigated daily on the unit. Is it really reflective of what you're seeing in your data? And if not, go back to your data and do a deeper dive and truly understand what's there. I've often gone back to Monica, our board coordinator here at St. Thomas, and we'll question and say, this isn't making sense for me. Can you help me understand? Help me do a deeper dive on this? Because without that information, I can't help the team move forward. Also be very clear in terms of what you're trying to achieve. That needs to be clear for the staff so that, and that's why we have indicators on a huddle board. This is what we're focusing on right now. This is what we're putting all our time and energy into to make this meaningful change. Keep your stakeholders engaged, so as you make the change and it's sustained, move into another indicator so it keeps them engaged in terms of that continuous improvement. Communication, daily basis. This is not something that you can parachute in, do a small quick change, and then move away from and leave it with the team. You've got to be visible, you've got to be engaged to move that forward. They also need to know that you're there to support the movement forward, so when there are crucial or tough conversations that they're having a difficult time with, you can continue to mentor them, but you can also intervene if there is a need to. Monitoring your changes and your metrics. Again, this is a daily component that needs to become part of your day that you do every day. Making sure that you're following up on your compliance, and that will lead to your sustainability. So here you will see our dashboard for September to November of 2013. You will see two of the metrics who have been have a 0. We've maintained the metric 1 of the newborn screening at 0 for now 10 months, which I'm really proud of the team for. Our proportion of inductions at 41 weeks, you can see that sitting at a 0. That's been there for a couple of months as well. The two indicators that we've now, as I said, we've just now moved our attention and direction to is the cesarean section, low risk 37 and 39 weeks. That has just gone on to our leadership review, quality safety review board, and also our metric on our huddle board daily. We certainly have identified some systems issues and that are inhibiting the fact for them to book the cases at 39 weeks or just after, of which we're doing some deep dive and strategy on that. The second one that we will be looking at, as I said, as we move forward with the BFI initiative, is our formula supplementation. In addition to that, we recognize that it's also identified our population for us. We have a very high Mennonite population who have an embedded culture of formula feeding until their milk comes in, and we're trying to get some education out to this group in terms of breastfeeding, but that's again a slow journey in terms of culture change, and so garnering the support of public health is going to be key in moving that metric. So those are two of the areas. But so we use this dashboard on a daily basis as it sits on our huddle board, and we celebrate these successes of the changes that we make, and the team can see on a daily basis as we move our huddle metrics forward, the time and the transition that they and the effort that they have put into it. So it's very rewarding for them at the end of the day as well, because they are the ones moving and driving the change on a daily basis. So as I like to say, it's just one step at a time. Continuous quality improvement is really not about making a massive, significant change. It's just that daily, continuous move forward. It's a step in the right direction, and it doesn't have to be flipping from 0% to 100% within a short period of time. So that concludes my discussion on our journey here at St. Thomas Hospital and how we are going to continue to move forward. And so I'll leave it to Sandy and any questions.
Thanks so much, Leanne. That was a wonderful presentation and a great example of of how you can move forward with data to help inform change, for sure. So I'll just remind everybody to take a second and think about your questions. You can type them into the chat box on the left-hand side of your screen. I did see a couple of comments that came through when Leanne was talking about the stakeholder group that she highlighted in her presentation on one of the slides, and someone mentioned add midwives, and another comment came in that said that she thinks that midwives were intended to be included in the clinical care team. So I don't know if you can confirm that, Leanne, or is there anything else you want to add to that comment while we give people a minute to see if there are any other questions?
So yes, on our clinical care team, as I said, it's an interdisciplinary team. So we do have the midwifery team represented at that table, as well as our physician groups, frontline staff, data analyst, and financial support at that table. So it is a very comprehensive group. Okay,
that's great. So maybe I don't see any other questions yet, but I'll just perhaps take the prerogative as the host to get my question in. I wonder if you could just talk with us a little bit about how you prioritize which indicators to select. I know you talked about, you mentioned the fact, you can't do everything all at once, and so it's a matter of making choices about how you move forward and what indicators become the priorities now and what indicators will be on the to-do list following. Can you elaborate a little bit on how you make those choices in your organization?
Sure. So as I alluded to in the presentation, for me what was really important is to, again, align with the strategic direction of the organization, and making sure that, if I wanted to make a change, that I would be able to really garner the support of the senior leadership team if I needed to make either, if it's infrastructure change or resource change or require finances, that I could utilize them to move that forward. The second key component for us really was around the discussion table of the clinical care team and all of the frontline staff and key clinician stakeholders was, some low-hanging fruit. We identified the newborn screening was one of the first ones that we had taken on to drive change, because we looked at the data, did a bit of a deep dive to understand what the challenges were, and put some strategies, fairly quick strategies in place to move that initiative forward. And I had a couple of really passionate staff members who wanted to help to move this initiative forward, so that was really beneficial to have that champion and passion to move an initiative forward. In terms of the induction component, as we know, inductions, like I said, the piece around the more interventions we do really can impact on the outcome. And so when you also looking at other reports, when you're looking at, the coroner's report and a variety of different things, it can help you make a decision in terms of why you want to look at a particular indicator first. And every organization may be a little bit different, but that's kind of some of the tools that we will use to actually decide on which indicator we're going to address. Likewise, because we do have our chart audit triggers, we do tend to keep our trends and have a sense of where some of our areas of focus need to be based on what trends we're seeing in terms of outcomes. And so we will tend to focus on those in terms of, quality patient care outcomes.
That's great. Thanks so much. I have a question here from Brittany. She says, at the very beginning of the chat, you mentioned going live with Hugo. Can you tell me what this is? Could you elaborate on Hugo for us?
Sorry, yes. So Hugo is physician order entry, electronic, and also closed-loop medication, so scanning of the patient, scanning of the medication, and then delivering the medication. So that piece is now all done electronically. So.
Okay. Carlene asked, Leanne, it would seem that you were the driving force to use this approach to integrating BORN this way in management strategies. Any suggestions for providers, managers who play different roles? How could we introduce this creative way of quality assessment, I think is what she means by QA.
Again, I think it's really escalating and elevating the importance of using our data and metrics that are at our fingertips to drive the change forward. If you have a quality committee or team, moving that report forward and showing where some of the gaps might be is very helpful. Moving it forward to the risk team, if you have a risk team, is really helpful. Also engaging some of the key clinicians, frontline staff and or physicians who can start to garner support to move that area forward in terms of, what are our metrics? What are we measuring? What are we doing well? What are we not doing well? Asking for the data and understanding it.
Okay. It actually ties in quite a bit with your comments on communication and networking and having the right stakeholders around the table as well, which you did emphasize quite a bit. I have a question from Shannon as well. She says, does St. Thomas do electronic documentation in their labor and delivery, postpartum, and ICU areas? If so, what product? And do they do an auto-upload to BORN? Do they have a BORN coordinator at the hospital or a dedicated IT clinical person responsible for BORN?
So, no, we're not electronic yet. That is on the docket for this coming year for March for our capital list. And we haven't made a decision. Obviously, we'll have to go out to an RFP.
Yeah.
I am familiar with a few systems. OB TraceView is one of the systems I'm very well aware of, and I do know that it can do the mapping and automatic upload of BORN. We do not have a BORN coordinator here at the hospital. I am ultimately accountable to BORN data. I'm an administrator here within the program. I have educated a variety of staff to also do some admin supports and do the ability to run reports. As I said, my data analyst also has access to BORN and will run regular reports for me if I don't have time to pull the report. And then with respect to the BORN, as I said, it's real time for the staff. They know the BORN system very, very well and do the data input as they're providing their care directly.
Okay, that's great, and you did a great job emphasizing the importance of data quality and following up on data quality issues once they're identified, because relying on the data in order to identify practice issues and move quality improvement along, you have to be confident in the data that you have as a place to start for exploring the practice issue, and that came across from my perspective really loud and clear in your presentation. those are the questions I have on the screen. I just have one more myself, maybe if you wouldn't mind. And it's, you talked quite a bit about communication, and I wonder if you could elaborate a wee bit about how you talked about the importance of communicating with everyone, but could you tell us about your communication strategies in the hospital and how you reach all of the important people that need to be made aware of the progress, strategies, process, and how do you know that they've actually heard and received the information? How do you network with everybody in a way that the message gets through?
So communication for me is absolutely critical. So there's a variety of strategies that I take in terms of communication. So I have a tool that's called, you would have seen on the screen there, was called FYI Friday. It's a news report that I publish every Friday with all of the practice changes, strategies, and a variety of things. And I'm happy to send one out so you can get a sense of what is communicated in there. And this goes out to all of the physician group, senior leadership, and frontline staff, midwives, public health, so that everybody is on the same page and hears the same message from myself. The clinical care team, so it's an interdisciplinary body of discussion around, what initiatives we're taking on or what changes or strategies we've developed to move forward. That is circulated in our minutes of the meeting, which is posted, again, through that whole group that I've just talked about with the FYI Friday. Mm-hmm. The senior leadership team is apprised through our quality risk huddle on a weekly basis, so every Wednesday they get their update at that particular meeting. And the strategy map for the program. So I have developed a strategic map for the Women's and Children's Program, which dovetails with the organization's strategic map, but it's very clearly identified what initiatives we're taking on and timelines with it, and it's posted right beside my huddle board so staff can see it and review it on a daily basis.
That's excellent. Quite a variety of different approaches. I have a question here from Sarah. Could you tell us what approximate birth volumes St. Thomas sees? What's your birth volume in your hospital?
We only do about 800 births right now.
Okay, 800 births. And you have an NICU as well, you said?
We do, yes.
Yeah.
Level 2.
Level 2 NICU. Okay. And I'm wondering if you could, you talked quite a bit about setting up this effective process of problem solving for solutions for each KPI, and you mentioned in your last slide it looks like the supplementation indicator and the elective repeat cesarean section less than 39 weeks indicator are two that are next on your list for exploration and moving forward. And you mentioned the supplementation is complicated by the population that you serve, in that there's a common practice among the Mennonite community to combination feed. And how do you see that moving forward? How are you going to tackle that issue if it's a cultural issue?
Yeah.
It may not be a fair question because you're in the beginning stages of exploring it, but it was just intriguing, and I wondered if you had any thoughts.
Yeah, so as I said, public health has been very much a part of our team and really critical in terms of moving initiatives forward.
Yeah.
And they have an individual on their team who is quite embedded in the Mennonite population in terms of developing a relationship and sharing some education with some of the seniors within that community. Mm-hmm. And so that's going to be really critical of engaging them. We're anticipating and hoping as we move forward with the BFI, as the Southwestern region, as you might know, have all signed on to move forward to BFI.
Yep.
And so we're hoping to bring them members of the community to the table as we start looking at some of the strategies, initiatives to make some changes within our organization. So almost patient advisors, and hopefully with some of the education, it's going to be, I mean, culture is certainly more difficult to change, but perhaps with them being at the forefront as we go through this journey, we may start to have some influence. I can't say yet because, as I said, we don't have any defined initiatives at this point in time that we will be able to actually develop metrics for.
Yeah. Well, thanks. That's great. And again, I know it probably wasn't a fair question at this stage of the game. I don't see any other. Oh, here's one question. Sorry. So we have a question. We are in the process of exploring the concept that our supplementation rate is higher due to length of stay being higher than other hospitals with lower supplementation rates. What is your average length of stay?
We're usually between 24 and 48 hours.
Okay. I don't know how that compares with the site questioning, but there you have the answer. And another question. I like your strategies for baby-friendly initiative promotion. This was all great. Thank you for sharing this success story. Bye now. And that's the end of the questions on my screen. Did you have any other comments you wanted to make or any other thoughts just as the last minute before we do sign off? We just have a minute or two left.
No, I have left my contact information there. If anyone wants either further information, or to come for a site visit to see how the huddle boards and whatnot work, I've had a few organizations come and do that. I'm happy to share any resources or tools, so feel free to contact me.
That's just tremendous, and we really appreciate you leaving your contact information on the last slide. And so even people who haven't had the opportunity to listen in today and listen into the webinar in the future, you may get calls in the future as well, because that's something that's critically important in moving things forward from a knowledge translation perspective is sharing successes and sharing best practices around making change. And it makes a big difference to actually really go and connect with sites who are working towards change themselves. So we appreciate the time. We appreciate your hospital support and your support, Leanne, in coming on to our Born Provincial Rounds today and sharing this story and what a transformational journey it has been. It's a marvelous, marvelous story. You should all be commended because you are a model organization for sure. So we appreciate your time. Thank you so much, everyone, for joining us today. For those of you that join us regularly, our next rounds will be the third Thursday of March, March 20th. You stay tuned early in March for the flyer coming out to announce rounds once we have the speaker confirmed. And I'll sign off then for all of us. And on behalf of Born, thank you, and Leanne and Monica Poole, who is our Born coordinator, who helped to facilitate this connection with Leanne and St. Thomas and bring this topic to you today. We appreciate your time, and I hope you have a wonderful rest of the day. Thanks so much, everybody. Bye now.